I'm going to speak with you about some of the basics of what we do in this series of presentations, beginning with amblyopia and then exotropia, and finally, infantile esotropia. These are helpful for those of you who are in training, but also for those who have been out for a while as a review. I'm going to begin by speaking to you about guidelines for amblyopia management in 2021. The principles of treating amblyopia involve clearing any image blur and encouraging use of the amblyopic eye through preventing use of the better seeing eye. That's been known for some time. The Pediatric Eye Disease Investigator Group, or PIDIG, which was funded by the National Eye Institute, has recruited pediatric ophthalmologists and other eye care professionals from around the United States to participate in prospective randomized multi-center clinical studies designed to allow an adequate sample size to definitively answer questions about treating amblyopia. The following slides summarize these studies to date, which form the basis of many of the preferred practice patterns in 2021. Though occlusion treatment has long been the accepted standard for treatment of unilateral amblyopia, the details of how to patch were often debated as a matter of personal preference on the part of the prescribing ophthalmologist. Two early PIDIG amblyopia treatment studies tested the efficacy of different patching regimens for children with strabismic or anisotropic amblyopia. The first study evaluated children with severe amblyopia, which was defined as visual acuity between 2100 and 2400, and found that 6 hours of patching per day was just as effective as full-time patching in children 3 to 7 years of age. And a second study, looking at children with moderate amblyopia, defined as visual acuity between 2040 and 2080, found that 2 hours of patching per day was just as effective as 6 hours per day in this same age group. Therapy preventing the use of the sound eye can be achieved by defocusing the sound eye, usually with atropine drops. In the first study, PIDIG compared the efficacy of daily atropine penalization of 1 drop per day and compared that to 6 hours per day of patching in children 3 to 7 years of age and found they were equally efficacious. They then studied children with moderate amblyopia and found that weekend atropine was just as effective as daily atropine, 1%, in this age group. In children less than 8 years of age who were treated successfully with atropine or patching, 24% of children had a recurrence of the amblyopia within the first year of treatment cessation. And there was no difference as to whether that treatment was with atropine or occlusion treatment. This data also suggested that abrupt cessation of patching, when the patching was happening 6 or more hours per day, was associated with a higher risk of recurrence. So the bottom line here is that you need to monitor children after you stop amblyopia treatment, and particularly to avoid abrupt cessation with higher levels of treatment. Make sure to taper in those cases. To find out if correcting refractive errors alone improves vision in the amblyopic eye, PIDIG studied children 3 to 7 years of age with previously untreated anisotropic amblyopia and found that amblyopia improved 2 or more lines with correction of the refractive error alone in 2/3 of children ages 3 to 7 and in 1/4 of older children. There were better outcomes with better baseline acuity and lesser anisotropia. And so the lesson here is that initial treatment may begin with correction of the refractive error alone. Another question regarding treatment is whether or not to recommend treatment in older children. These data showed that even older patients can show improvement in visual acuity in the amblyopic eye, and this represented a significant change from previous consensus opinion about when amblyopia treatment becomes useless. So they found that in children ages 7 to 12, optical correction alone showed an improvement in 1/4, and half improved when this was combined with patching or atropine. And in older children, ages 13 to 17, 47% with no prior treatment responded to optical correction and patching versus only 16% who had had prior treatment. So the lesson here is that even older children can show improvement with amblyopia treatment. How cost-effective is amblyopia treatment? To perform a cost-utility analysis of treatment, researchers referred to the Academy's preferred practice pattern guidelines for amblyopia to determine the cost-effectiveness of amblyopia treatment. And they found that amblyopia treatment was highly cost-effective when all the costs were taken into account, such as office visits, patches, glasses, and surgery, when required, compared to many other treatments in eye care. Not only is the treatment itself relatively inexpensive, but the results of treatment can impact someone's life for many years. However, patching is disliked by parents and families, and compliance with patching has been reported to be as low as 44 to 57%. Thus, noncompliance is a major barrier to successful treatment. Atropine penalization has a higher acceptance rate than patching and may be used as an alternative. However, there are concerns with blurring the good eye in school-aged children through the school week, and some children may experience allergies to atropine or to the adhesive in patches. Effective alternatives to patching and atropine are being investigated. One such treatment are these Ambly's glasses, which are liquid crystal display lenses that provide intermittent occlusion via intermittent occlusion of the dominant eye. A study published in the Journal of APOS found that when these lenses were used in children ages 3 to 8 for 4 hours per day with a 30-second cycle of alternating occlusion and clear lens over the dominant eye, that treatment provided similar results to 2 hours of patching per day. The authors recommended a randomized clinical trial to further evaluate these lenses. Non-adhesive felt patches may also be better tolerated by some children as long as they do not lift the patch to peak. Vanguard or filters may also be an acceptable option for children with moderate amblyopia, as shown in a PEDIG study. So in conclusion, consider atropine drops or lower treatment recommendations, as we discussed earlier, or switch to other alternate treatment modalities if allergy or noncompliance is a problem. Binocular treatments are new developments that are undergoing study in the management of amblyopia. Classically, amblyopia has been considered a monocular condition. However, binocular imbalance and inhibition, suppression, and impaired binocular vision are also considered important characteristics of amblyopia. Targeting these first in amblyopia treatment via binocular dichoptic training, where the images are presented to each eye separately, may better address a number of decreased visual functions related to amblyopia. In this type of treatment, a child may wear red-green glasses and play some computer game where the images are presented to each eye simultaneously. The image to the dominant eye may be reduced in contrast. Early case series showed some promising results. However, a randomized trial reported by PEDIG in 2016 showed that improvement with the particular type of dichoptic treatment used in one study was not as good as 2 hours of patching per day. However, compliance with treatment was poor, with only 22% of the children using the game for at least 75% of the prescribed time. Likely, the game became tedious to continue over a prolonged period of time, and it was felt that improvement and variation of the game or use of movies might help improve compliance in the future. A second trial did use a more interesting game, but found no benefit to vision or stereopsis after 4 to 8 weeks of treatment in children who were aged 7 to 12 years. A new PEDIG study is evaluating whether dichoptic training is a benefit in a younger population, those children aged 4 to 6 years. So for 2021, whether binocular treatments for amblyopia are at least equivalent to patching and atropine remains to be seen. It's important to note that in all of the PDIG amblyopia treatment trials, children with a visually significant anatomic abnormality or prior history of intraocular surgery were excluded from surgery. However, such children may have amblyopia in addition to or secondary to their ocular abnormality, and the component of vision loss due to amblyopia may be amenable to treatment. So these children must be approached on an individual basis with a treatment plan, an endpoint for treatment success or cessation of treatment based upon each individual's circumstances in response to treatment. For example, in the infant aphakia treatment study, there was a recommendation for 1 hour per day of patching up to 8 months of age, and then half of waking hours for monocular amblyopia. Although the amount of patching and adherence to this recommendation was considerably less, the data suggested that adherence to occlusion therapy throughout the first 4 years of life contributed to better visual acuity in children treated for unilateral congenital cataract, although there was considerable individual variation. So you might use these data to support the caregiver's continuing efforts to prescribe patching and provide them with encouragement about the efficacy of patching, even if they have been unable to fully adhere to the prescribed patching regimen. It's important to monitor for reverse amblyopia with high levels of patching or penalization. And finally, it's important to prevent vision loss in the sound eye through appropriate monitoring for reverse amblyopia and the prescription of polycarbonate lenses for protection from trauma. Amblyopia is a common vision disorder that, if left untreated, can result in visual impairment. The amblyopia treatment studies conducted by PDIG have provided evidence to guide treatment paradigms used in current clinical practice. These include recommendations for treating mild to moderate amblyopia with patching of 2 hours per day of the dominant eye and 6 hours per day for severe amblyopia. Atropine may be substituted for patching. Consider Bangirter filters as an alternative for moderate amblyopia where compliance with patching has been difficult. Correction of the refractive error may improve anisotropic, strabismic, and bilateral refractive amblyopia. Older children may respond to amblyopia treatment. As we discussed in a PDIG study, you need to monitor children after treatment is discontinued. Standard treatments for amblyopia are highly cost-effective, and new treatment modalities are under investigation. We'll now turn our attention to preferred practice patterns for intermittent exotropia. Disclosure: I'm a board member of the American Academy of Ophthalmology. And a primary source for this presentation is the American Academy of Ophthalmology preferred practice patterns. I have used other sources and will list those where applicable. A good source for preferred practice patterns in general are these monographs produced by the Academy, and they're available in a wide range of subjects. They're developed by content experts and reviewed by many individuals and organizations within the Academy. This one was developed in 2017. Each guideline is reviewed annually and is good for 5 years, and they're based on the best scientific evidence available and provide guidance for a pattern of practice, though judgment has to be used in the care of each individual patient. Intermittent exotropia is the most common type of exotropia. Intermittent exotropia is frequent in neonates, but resolves in most by 3 to 4 months of age. Childhood onset exotropia is typically intermittent and has an onset before age 3, but may be detected later in childhood. Tends to occur with fatigue, inattention, or illness. It's often characterized by monocular eye closure in sunlight. Mild amblyopia may occur, and suppression is more common, though diplopia may be noted. This is a paper that Dr. Van Noorden and I wrote during my fellowship training about the frequency of monocular eye closure in sunlight in children with intermittent exotropia, though we also noted that it occurs with other forms of strabismus as well. Exotropia occurs in about 1% of the population. The cause of intermittent exotropia is poorly understood, though several risk factors have been identified, such as tonic divergence or mechanical or orbital factors. Risk factors for intermittent exotropia include prematurity, perinatal morbidity, genetic disorders, a detrimental perinatal environment such as maternal drug use, smoking, a family history, female sex, and astigmatism, myopia, and anisotropia. Finally, severe unilateral or bilateral vision loss may be associated with exotropia, though it's more commonly seen in adults, whereas esotropia is more common in children. With regards to constant infantile exotropia, about half of these children may have associated ocular or systemic abnormalities. Generally, as we noted, patients do not note diplopia, though some are aware of it. Ask about what proportion of waking hours the strabismus is present and when it occurs, such as when the individual is tired, ill, daydreaming, or viewing distant objects. Ask if the frequency is changing and which eye turns. Is the deviation constant or intermittent? By history or on exam? Measure the alignment using prism and alternate cover testing at distance and near and an up and down gaze to check for A or V patterns and in lateral gaze. And measure stereoacuity first before checking the vision with a patch to avoid dissociation and worsening of the strabismus. Well, what's the natural history of intermittent exotropia? Some studies suggest many patients remain stable over time. There is occasional spontaneous improvement with this condition, whereas others report deterioration of control over the long term of 75% of patients, and a small percentage may progress to a constant exotropia. This commentary regarding a pediatric study from 2019 relates to the findings that 15% of children with exotropia deteriorate over a 3-year follow-up period, and indicate it would be nice to have long-term follow-up on this cohort. How is intermittent exotropia managed? First, correction of refractive errors, stimulating accommodative convergence by overcorrection of myopia or undercorrection of hyperopia, patching, amblyopia treatment, prism therapy, convergence exercises, and extraocular muscle surgery or Botox injections. Correction of significant refractive errors may help control the alignment, and although high hyperopia should be corrected, correction of mild to moderate amounts of hyperopia are generally not recommended, as this relaxes accommodative convergence. One non-pediatric study showed that myopia developed frequently in children with intermittent exotropia by 20 years of age. Well, what about stimulation of accommodative convergence by over-minus lens therapy, typically by -1 to -3 diopters? A pediatric study published this year suggests that while therapy may improve control while the glasses are being worn, the improvement did not persist after the glasses were discontinued, and also raised a concern about the potential for treatment worsening myopia. With regards to patching therapy, in some cases, part-time patching of the dominant eye or alternately patching 2 to 6 hours per day may help improve fusional control or reduce the angle of the strabismus, particularly in children ages 3 to 10. 2 randomized trials have found deterioration is uncommon in intermittent exotropia, as discussed earlier, though patching may slightly lower the risk of deterioration. Treatment of amblyopia may improve fusional control or decrease the angle of strabismus and improve the post-op success rate. But remember that marked amblyopia is unusual with intermittent exotropia, and a significant decrease in vision should prompt consideration of a structural etiology. Prisms are not generally prescribed since diplopia is infrequent with intermittent exotropia. They're most useful with the convergence insufficiency type intermittent exotropia, with either base out prism with convergence exercises or base in prism and no improvement with exercise. Extraocular muscle surgery is considered when there's a constant exotropia or a frequent or large angle exotropia that is unacceptable to the patient or caregivers, or poor response to non-surgical treatment. We want to measure the alignment at distance and near on an accommodative target with the best correction and at a remote distance if possible. 30 minutes of monocular occlusion may elicit the full deviation. With constant infantile exotropia, early surgery may help improve the sensory outcomes, though the binocular function is rarely completely normal. This child underwent surgery for a constant infantile exotropia at 1.5 years of age and thus far has maintained good alignment. With intermittent exotropia, the more common type, many surgeons do wait until the deviation is very frequent, and there are psychosocial implications, such as the child getting teased at school, but avoiding early surgery to avoid the risk of esotropia, amblyopia, and loss of stereopsis that may occur with overcorrections. Most surgeons prefer bilateral lateral rectus recessions, but a large clinical trial by PEDIG showed that in children aged 3 to 11 with the basic type of intermittent exotropia, similar measurements at distance and near, found no difference in results between lateral rectus recessions bilaterally or a monocular lateral rectus recession and medial rectus resection. A small angle consecutive esotropia is usually temporary and may increase the chance for long-term alignment. If it persists, you may need to treat it with prisms or additional surgery. Short-term results with bilateral lateral rectus recessions are good, but recurrences are common in the long term. With regards to botulinum toxin injection, in one study, Botox was less successful than surgery, and another found a better success rate, though still not as good as strabismus surgery. There's insufficient evidence at this time to make treatment recommendations for botulinum toxin and exotropia. Children with good control and without amblyopia should be followed every 6 to 12 months. By age 7 to 10, the frequency of exams may be reduced. And in one long-term study, with at least 10 years of follow-up, 60% of patients required at least one operation. So prepare yourself and your patients that another operation may be needed for long-term control. And the final presentation in this series is on infantile esotropia. There are many recommendations on the treatment and timing of treatment for this condition. So where do we begin? Well, again, we're going to use the American Academy of Ophthalmology's preferred practice pattern as our primary resource, and I'll identify others where applicable. What's the definition of infantile esotropia? Well, it's an onset before the age of 6 months without spontaneous resolution. And note that intermittent esotropia may be present in the first few months of life and may resolve. We'll speak a little bit about that later. It's non-accommodative or partially accommodative, so generally the refractive error is typically 3 diopters of hyperopia or less. There's a constant angle of deviation, which can increase with time, and cross-fixation is common with the fixating eye in adduction, which may help prevent amblyopia. What are associated findings with this condition? First is latent or manifest latent nystagmus is common, as is dissociated vertical deviation. What appears to be oblique muscle dysfunction has actually been shown to be due to heterotopic muscle pulleys leading to A or V patterns. And under monocular viewing conditions, you may see optokinetic nystagmus asymmetry. So when the drum is rotated from temporal to nasal, you get a brisk response, but you get only a weak response when the drum is rotated from nasal to temporal, as shown in the photograph on the right. These are two British ophthalmologists who had different hypotheses as to the cause of infantile esotropia. The first, Claude Worth, on the left, is famous for the Worth 4-dot test. Well, he believed that esotropic infants suffered from an irreparable defect of the fusion faculty and that their brains were incapable of achieving substantial binocular vision. He said surgical treatment to restore binocular vision was futile and not worth it. Chavez, on the other hand, believed the potential was present for fusion in esotropic infants and that this potential was due to a problem with the motor system. He felt if this problem could be addressed surgically, then some degree of binocularity could be restored. The debate and research has been ongoing since, and perhaps there are some infants that fit into each of these categories. Well, how common is infantile esotropia? In this study that you see with data on the right, using the Rochester, Minnesota Epidemiology Project, where patient records are linked and available for research, it was found that infantile esotropia is relatively uncommon related to other types of esotropia. Rates of esotropia, though, have been reported to vary in different populations, different countries. In this study reported here, there was no change in the incidence over a 30-year period of this condition. Well, what's the natural history of early onset esotropia? Well, I mentioned earlier that Pittig had performed a study back in 2002 that infants with early onset esotropia, that the esotropia often resolved in 27% of patients by 7 to 8 months of age. But generally, these were children with smaller angles of esotropia, and it was unusual for esotropia with 40 prism diopters or greater to resolve. Therefore, remember that esotropia with an onset very early in infancy may resolve, particularly when the angle is less than 40 prism diopters, when it's variable or intermittent. So in terms of the history, look for a history of a constant esotropia persisting after 2 to 4 months of age, particularly a larger angle strabismus. There may be a history of prematurity and low birth weight associated with an increased risk of infantile esotropia. But these children are otherwise neurologically normal. The family history is frequently negative, though there may be a multifactorial genetic basis for infantile esotropia. And it's been noted that monofixation syndrome is 11 times more frequent among first-degree relatives of patients with infantile esotropia than in the general population. So on examination, you're looking for low amounts of hyperopia, less than 3 diopters, moderate to large angle esotropia, greater than 30 prism diopters. Amblyopia occurs in less than half. Cross fixation is common. Latent nystagmus is frequently observed. And associated vertical deviation and inferior oblique overaction are frequent after 2 years of age. And remember the optokinetic nystagmus pursuit asymmetry we discussed. Here is a differential diagnosis for infantile esotropia. These include accommodative esotropia, Abdusen's palsy, Duane syndrome, restrictive esotropia, congenital fibrosis, sensory esotropia, and nystagmus blockage syndrome. The management for infantile esotropia is typically surgical. but remember to consider medical management first. Surgical treatment typically consists initially of bilateral medial rectus recessions. An additional surgery may be necessary to address A or V patterns, although one study reported in the Journal of French Ophthalmology suggested that A and V patterns may improve in some cases with horizontal surgery alone. It's been debated as to whether 3-muscle surgery versus large medial rectus recessions for large angles should be considered. Better binocular vision has been shown if the surgery is done prior to 2 years of age, and some advocate for very early surgery. Early surgery may reduce the incidence of late nystagmus and associated strabismus. The monofixation syndrome is a typical outcome, and successful treatment with a heterotropy up to 8 prism diopters and a central suppression scotoma on binocular viewing, and reduced stereopsis and presence of peripheral fusion is considered a successful outcome. Additional benefits of treatment include development of a positive self-image, self-esteem by the patient. Success is high in the short and medium term, but reoperation rates ranging from 25 to 69% have been reported, depending upon the length of follow-up. The longer I've been in practice, I certainly see patients that had good outcomes as children only to develop a consecutive exotropia many years later. In addition to the rare risks of strabismus surgery, such as endophthalmitis, the potential risk of neurotoxicity secondary to general anesthesia versus risks of delaying surgery has received attention. But it's suspected that any developmental issues related to strabismus surgery in children occurring would, if at all, would likely be minor. Botulinum toxin injection is another treatment where there's temporary weakness of the medial rectus muscle associated with long-term contraction of the antagonist lateral rectus muscle. It's an alternative to incisional surgery, particularly for small to moderate deviations, say those 35 prism diopters or less. The advantage, short anesthesia, no incisions. Potential disadvantages, ptosis, which could predispose to amblyopia, globe perforation, delayed binocular misalignment. More than one treatment may be needed, particularly for large angles of strabismus, and it may also be used to augment medial rectus recessions for large angle esotropia. Infantile esotropia requires long-term follow-up for both alignment and vision. And recurrent esotropia requires cycloplegic refraction and correction of hyperopia before assuming the recurrence is non-accommodative. Educate your patient, your parents, and the caregivers regarding the nature of the long-term management and importance of long-term follow-up, as this increases the chances for adherence to treatment and success.